is going to share his slides. One question: should presenters keep their camera off too, or what's the sort of?
It's at your discretion. Either one. I think as long as it's just not everybody in the call, that's just fine.
There. All right. And you can hear me okay?
Sure can. And now we see you too. And we see your slides as well.
Excellent. Well, hi, everybody, and thank you for that nice introduction, Kathleen. As she said, I'm Dan Muldoon. I'm joined by my colleague, Yixuan Song, where we'd like to first say thank you to the Actuaries Club of the Southwest for inviting us to present, as well as Felice Tumel and Richard Wu for extending the invitation. And we're here today to talk about the Medicare Advantage value-based insurance design, or VBID model, and specifically focus in on the hospice component of that model. So next slide. So these are just some typical disclaimers that we, Yixuan and I, have given that we are federal employees about the presentation. So next slide. And so today we're just first going to give a little bit of background about the Center for Medicare and Medicaid Innovation, or CMMI, talk about how hospice is covered and paid for in traditional or fee-for-service Medicare, a little bit about how Medicare Advantage beneficiaries access the hospice benefit, and then get into how that works differently in our value-based insurance design model. And then to close it off, we'll go through some of the early evaluation results that we're seeing from our model. So next slide. So the Center for Medicare and Medicaid Innovation was created through Section 3021 of the Affordable Care Act way back in 2010. Was sort of the statutory authority to test innovative payment and service delivery models to reduce program expenditures, with a focus on sort of three key scenarios for what we see as success for a model. The first being improving quality for beneficiaries in the Medicare or Medicaid program without increasing the cost of those federal programs. You could maintain quality while reducing costs within those programs, or ideally both improving quality and reducing costs. If a model meets any of those criteria, then there's also statutory authority to expand that model to test it on a sort of broader basis within those programs. Next slide. In terms of how we think about innovation, we test alternative payment models to reward providers for new approaches to delivering highly efficient, cost-efficient, high-quality care. The APMs that we have in our portfolio typically have between 20 and 30 that we're testing that can look fairly different. They might focus in on a specific health condition. We have models that we're testing for beneficiaries with end-stage renal disease or who are receiving cancer treatment for cancer treatment in the Medicare program. We might look at certain procedures such as joint replacements, different types of providers. We have several models in our history that have focused in on improving access to comprehensive primary care, might focus on specific communities like beneficiaries or providers in rural areas. And then today we're going to spend most of the time talking about is some of the innovation that we are working on within Medicare Advantage and Medicare Part D, where we interact with health plans to sort of give them additional flexibilities to offer different types of benefits that aren't always or typically covered through those programs. Next slide. This is just the sort of overview of our model portfolio, with the model tests that are highlighted in blue as the models that are active or announced as of earlier this year. Models in black are those which have ended but have an ongoing evaluation, again, spanning multiple domains, from accountable care, where provider group or group of providers takes on full accountability for the beneficiary's cost and quality of care, episode-based models where we focus in really on specific sets of services that are either clinically or temporally related, transforming primary care, accelerating the development of new payment or delivery models, which is where that VBID model sits. Some initiatives that focus really on beneficiaries who are dually enrolled in the Medicare and Medicaid program and trying to better integrate care for those beneficiaries, where it can often be fragmented based on which services fall under the Medicare benefit versus the Medicaid benefit, and trying to reduce and remove some of those frictions. And then we also have some initiatives that are really focused on speeding the adoption of best practices. Next slide, please. These are just some very high level numbers about the reach of the models that we test at CMMI. These are from our most recent report to Congress, which came out at the end of last year, covers a 2-year period of time. So 2021 and 2022, around 41 million beneficiaries who were affected by our models. That sort of spans the Medicare program, the Medicaid program, as well as some commercial plans if their plans were for plans who are participating through a CMMI initiative as part of one of our model tests that included a multi-payer dimension, like our Maryland total cost of care model involves setting hospital global budgets that sort of are effective sort of across the entire population of Maryland, regardless of someone's insurance coverage. During that same period of time, we also had around 314,000 providers who were part of our CMMI model test. Next slide, please. So as we look forward, right, as mentioned earlier, CMMI came out in 2010. We've been around as a organization within the Centers for Medicare and Medicaid Services for a little more than 10 years now. And so we've been looking forward to what is going to come in the next 10 years, and really where we're driving towards today with our strategic decisions around what models we will be testing is towards a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And we see really 5 structural pillars in terms of how we drive there, in terms of driving accountable care, advancing health equity, and focusing on where disparities exist for the beneficiaries in our programs and how to potentially address those disparities, supporting innovation in different types of payments and care delivery, addressing affordability, and partnering to achieve system transformation with both federal and non-federal partners. Again, the VBID model we really see as fitting under that middle pillar of supporting innovation, in that through not only the hospice component, but other parts of that model, really offering additional flexibilities to the Medicare Advantage organizations that participate in the model for them to allow different types of benefits for the beneficiaries who are in their plan. Next slide. So now we'll then talk a little bit about how Medicare pays for hospice within the fee-for-service program. So the hospice benefit is really a comprehensive, holistic program of care to support terminally ill patients as they move from focusing on curative care for their health condition into palliative or comfort care as they near their end of life. Beneficiaries who meet certain eligibility criteria can receive these hospice services. Namely, they have to be receiving those services from a hospice who's certified by Medicare. The beneficiary's attending physician, as well as a physician at the hospice, have to certify that the patient is terminally ill and that there's an expectation that the patient will live for 6 or fewer months. And then the patient has to elect to receive the hospice benefit. And as part of that election, they waive their right to have Medicare pay for non-hospice services that are related to that terminal illness. When beneficiaries elect their hospice, initially it's 2 90-day periods, but then they have unlimited 60-day periods. Next slide, please. As I said in the last slide, the hospice benefit really does offer a comprehensive, holistic suite of services that includes nurse practitioner, physician services, medical supplies, drugs for managing their pain and symptoms, social work, physical therapy, also dietary and spiritual counseling. Also offers some payments for respite care for caregivers for beneficiaries. And so really it's designed to be sort of the totality of services that a beneficiary needs as they're sort of in this period where they've moved to focusing on comfort care. Next slide, please. Within the Medicare hospice benefit, make a daily payment for beneficiaries in hospice, regardless of the number of specific services on a given day, including on days where beneficiary has elected hospice but did not actually receive any services. There's sort of 4 levels of care that range from routine home care for beneficiaries, which is provided on a non-continuous basis, all the way up to inpatient respite care, again, to provide rest for the family caregivers of a beneficiary, or general inpatient care if a beneficiary needs to be admitted to a facility in order to access services that allow them to better manage their pain and control the symptoms that they have associated with their condition. Next slide, please. Now we'll talk a little bit about within the Medicare Advantage program, how beneficiaries who are enrolled in Medicare Advantage plans access the hospice benefit outside of our VBID model. And so I think here, the key thing to take away from this slide is that usually in Medicare Advantage, a beneficiary is enrolled in a Medicare Advantage plan, then they elect to receive hospice, is that Medicare fee-for-service starts to actually pay for all the hospice services that the beneficiary receives, right? As well as all the Part A and B services that are not related to the beneficiary's terminal condition. So the beneficiary can remain enrolled in their Medicare Advantage plan. The Medicare Advantage plan could still cover Part D drugs that are not related to the terminal condition, as well as any supplemental benefits that the beneficiary may have been accessing. But sort of the bulk of the payments for services the beneficiary receives for hospice and A and B services is coming through the traditional fee-for-service Medicare program. Should a beneficiary disenroll from hospice, though, then they would sort of move back to the Medicare Advantage plan, sort of taking back that control for coverage and payment for all of the Part A, B, D services, as well as any supplemental benefits. Next slide, please. This is just a couple of high-level data points. I think Yixuan and I should probably update this slide since 2017 is the most recent year, although I think probably most of the figures are correct, except that hospice payments have probably crept above $20 billion in the most recent data from 2021 or 2022. I think the key trends that we've observed, though, remain in that as of 2000, fewer than a quarter of decedents elected to use the hospice benefit, and that's increased to above 50% in more recent years. The average length of stay in which a beneficiary has elected that hospice benefit has increased from just over 50 days to just under 90 or around 90 days. Although you'll see the median number of days has not really increased that much, which I think is indicative of sort of additional weight in the right tail of the length of stay distribution, with sort of more beneficiaries who are having sort of much longer hospice stays. The payments for hospice from Medicare have again increased from under $3 billion to more than $18 billion, and most likely, I believe, over $20 billion in even years more recent than 2017. And then the number of beneficiaries who use hospice increased from around 530,000 beneficiaries to nearly 1.5 million beneficiaries each year. And so that's just a snapshot of the hospice benefit use and Medicare payments for it. At this point, I'm going to turn it over to Yixuan to actually start to get into talking about the Medicare Advantage VBID model and what we're testing there as it relates to hospice.
Thanks, Dan. So starting on this slide, since 2014, MedPAC has raised the issue around the carve-out of hospice from MA. And so consistent with the Innovation Center's broader portfolio, we're attempting to address the problem that MedPAC and other stakeholders have identified with the current hospice benefit carve-out. And so through the hospice VBID, the VBID hospice component, the Innovation Center is hoping to bridge the gaps between Medicare Advantage and hospice providers through several ways. There are 7 primary elements of the hospice benefit component, which are shown here. For the sake of time, we won't actually go into what each of these represent, but you can find additional details about these on our website, which Richard had linked in the chat. So the MA VBID model will be extended through calendar year 2030, and we'll be introducing a variety of changes intended to more fully address the health-related social needs of patients, advance health equity, and improve care coordination for patients with serious illnesses. Under the model extension, beginning in 2025, we will be more closely aligning flexibilities for concurrent care with those that are currently offered in other Innovation Center models. Also, beginning in 2026, participating managed care organizations, health plans, will have more flexibility to require their enrollees to only receive hospice services from in-network hospice providers, as long as the plans meet our qualitative and quantitative hospice network adequacy requirements. This change is intended to ensure that model enrollees have greater care continuity and receive higher quality hospice care. We're very excited to continue this work on the model, and we encourage and invite you to let us know your thoughts on how we can make this model better for all of our stakeholders. And so now we'll switch gears a bit and talk about, get a bit more technical and talk about the hospice capitation methodology. In developing these capitation rates, we wanted to keep several policy objectives in mind. We wanted to create a simple, clear, transparent payment structure that aligns with the goals of the model, a few slides up. We also wanted it to be cost neutral, consistent with how the MA benchmark is developed, that many of the Medicare Advantage actuaries are quite familiar with, and of course ensure that the rates are accurate. The methodology that we are using have been in place since 2021, and various incremental changes have been made to improve on it over the years. But overall, broadly speaking, it remained intact for the past 4 years. Going from left to right and top down on this chart, at a high level, we're creating a national base rate for all hospice and non-hospice expenditures for members who are electing hospice. And then we multiply this by a monthly rating factor and a geographic adjustment factor to arrive at county level capitation rates by duration. Moving on to the second rule, some more specifics about how we develop the national hospice base rate. While the MA rate book uses 5 years of historical data, our internal analyses show that 3 years of hospice data provided the stability that we're looking for, given our goals, and is more responsive to the changes in experience in hospice and non-hospice expenditures. We then make some retrospective and prospective adjustments, and then we trend the data to the contract year. And where appropriate, we generally try to use the same trending factors that we use for MA rates. Then on the third row, we see notable differences, cost differences between the 4 different durations listed here. And consistent with our goals and policy objectives, we wanted to reflect those cost differences through a monthly rating factor. And then finally, on the last row, we're adjusting for geography, similar but not in the quite same way that we do for Medicare Advantage. And then lastly, it's worth pointing out that unlike Medicare Advantage payments, the capitation rates for hospice are not risk adjusted. This graph here shows the capitation rates for hospice that are incorporated into the overall MA payment structure. So looking at the first and third rows, for plans that are not participating in hospice, they are paid a risk-adjusted AP bid, MA rebate, and Part D payments and prospective payments for reinsurance and LIS. This is what most MA actuaries would be familiar with. But then looking at rows 2 and 4, the difference when a plan participates in the VBID hospice, VBID model's hospice component, is that we're making a hospice capitation payment in addition to all of those other payments that are made on behalf of the enrollees. The table here, the data here just provides an overview of the level of payments before we apply any geographic adjustments. The first column indicates the payment, whether it's in the first month or future months. And for the first month, we break out the payments based on the duration that they're in hospice. So naturally, if someone's in hospice for only 1 to 6 days for that first month, the payment is relatively low compared to other folks because we're providing less coverage overall. And now you'll notice that on the last two columns, we have a year one and a mature year column. The year one rate indicates counties that will be in the first year of hospice for 2024. And the mature year represent counties that have that had plans participate in VBID hospice in 2023. If you want more detail on the methodology and some other considerations that we make in developing these, we encourage you to check out the methodology memo published on our model website. I'll now talk about the hospice supplemental benefits in broad terms. Similar to the non-hospice supplemental benefits, you can buy down Medicare cost sharing, or you can add additional services. And those services would be limited to beneficiaries with a known hospice status. So beneficiaries who have elected hospice while in a MA plan. And consistent with non-VBID plans, the certifying actuary has discretion to either include or exclude the membership, hospice membership, when tabulating the PMPM cost of these supplemental benefits, both mandatory and optional. And again, you can refer to the bid pricing tool instructions for more guidance on this option. And finally, what we have listed here are some examples of the hospice supplemental benefits that plans can offer. You can go to the latest hospice application on our website to get a full list and other considerations for development of the supplemental benefits. On the specifics of BPT considerations, I would refer you to the bid pricing tool instructions for more guidance because it does change a bit year over year. But in particular, plan benefit package category 19C applies to the VBID model's hospice component. I'll now switch gears to talk about the 2020 to 2021 evaluation report for VBID hospice. Our contractors are hard at work on the 2021 to 2022 evaluation report, and we'll release that once it's ready. As a quick overview, in 2023, there were 15 MAOs, managed care organizations, participating with a total of 119 PBPs. The service area for these PBPs cover over 800 counties across 23 states and Puerto Rico. And for reference, in 2022, there were only 13 participating managed care organizations with 113 PBPs, covering 461 counties across 21 states and Puerto Rico. In this first evaluation report on the hospice component, our focus was more so on implementation and operations, with the idea that in future years, we'd be able to have more information and more data to dive into other aspects of this model. Our independent evaluation contractors leveraged a variety of data sources, including interviews with MA organizations and hospices, and used a variety of different types of analysis for this report. Each plan, parent organization, approached network development differently in 2021. At the most basic level, plans varied in their number of hospices that they chose to contract with. Some included 1 or 2 in their network, while others chose to contract with all of the willing and able hospices in their service area. And similarly, there's variation in the approach that plans used to pay their in-network hospices. Some offered full 100% of what fee-for-service Medicare was paying, and others offered haircuts, lower rates, assuming that there would be additional referrals or other services that would offset that lower rate. However, one common theme is that all of these plans, all of the participating plans have experience working with hospices prior to the start of the model. On the flip side, we found that most plans shared similar challenges related to data, communications, and other admin functions. But it was good to hear that these challenges largely diminished over time. Now, on the flip side, from the hospice's point of view, their interest in working with the parent organizations, the health plans, were driven by long-term business outlooks. That included thinking about the long-term effects of the model, wanting to get in early and be a early adopter of a relatively new model of care. But conversely, they shared concerns that the rates that they were being offered were insufficient and that there were additional administrative complexities that they were having to figure out from scratch. And we'll go into more examples of what those are on our next slide. So on the administrative piece, we can roughly partition these concerns into two buckets. The first is on reporting and oversight, and the growing pains of having to work much closer with plans than they might have in the past. The second is around the notion of supplemental benefits offered by the plans, and the hospices trying to figure out how they can help implement and actually deliver those to uh, patients who are part of the model. But even with all of those challenges, we found that for plans, leadership support, cross-functional teams, and other essential uh, collaboration efforts were key to a successful implementation of the hospice component. For hospices, success was driven more so by prior relationships with plans and uh, care management, case management practices. So let's now talk about the qualitative data analysis, the quantitative data analysis in the evaluation report. By and large, the utilization of hospice services were lower than participating plans were expecting in 2021. We have some aggregate numbers here on the screen on utilization of various hospice and hospice-related benefits. And even just looking at these numbers in aggregate, I'll just know that there's a lot of variation in utilization across participating plans. We won't get into specifics about each of those or the variances for those plans, but you can read more about that in our evaluation report. Again, moving on to the next aspect of our evaluation report, this time looking at networks. About a third of the VBID hospice enrollees in 2021 received care from an in-network hospice. But there was, again, significant variation across participating plans. And that makes sense, even at a high level, because participating plans, these parent organizations, were varying in how large or small they were having their networks be. The median in-network hospice provider provided care for around 16 hospice enrollees that are participating in VBID hospice. And for out-of-network hospices, that number was only 3. And lastly, if we compare the characteristics of in and out-of-network hospices, we see that the in-network hospices tend to be large. They tend to be part of a chain and more so located in rural areas compared to in-network, compared to out-of-network hospices. So we're on the last slide here. Uh, the hospice benefit component, it's an exciting change to how hospice benefits are delivered to beneficiaries. But I would say it's just getting underway. Both the plans and the hospices noted that substantial undertaking was required to operate and stand up VBID hospice in 2021. But as the year progressed and as we're heading into 2024, they saw that many of those challenges diminished over time. In the first year, we have not been able to detect any effects on enrollment, bids, premiums, or the cost of these supplemental benefits. But like I mentioned at the start, we do expect to have more data to work with in future evaluation reports to tease out if there is any effect. And in terms of final remarks, I'd say it's exciting. 2024 will be the 4th year of the VBID model's hospice component. The recent announcement about the model extension to 2030 means that we'll have more time to work with you all. The impact and the potential for creativity is pretty large, and we've only just begun to see the possibilities of incorporating hospice into the MA space. It's definitely important for us to hear from you for opportunities to create creative payment, contracting, value-based payment and service arrangements, and make it a win-win for all of us. I'll now pause and look through the chats to see if there's any questions.
There have been some questions. I think we have 3 questions in the hopper so far. The first one, why do you think the in-network hospices were located in rural areas compared to out-of-network?
I will actually have to get back to you on that. I don't remember off the top of my head. Let's go through the other questions. I can take a
Sure.
quick peek through
That sounds
the
great.
evaluation report.
Okay, what would you say the biggest difference you see or expect to see between hospice care that is covered under original Medicare Part A versus as a part of MA? Biggest difference in hospice care under those two.
Yeah, and hopefully we don't see any big negatives. Really our main goal in the earlier years was to essentially take hospice, which was historically only paid in fee for service, and rejig it so that MA models could operationalize and execute those services. It's not to say in future years, and we'd love to hear from plans on how they can increase their support and offerings for hospice compared to what we currently see under fee for service.
Okay, another question. For someone living in a state where MA does not have a direct benefit, do those individuals go back to traditional Medicare, or does MA default to traditional Medicare?
Sarah, could you expand what you mean by direct benefit? Sarah Lee.
Yeah. Oh, and Sarah, if you'd like to clarify your question, you are free to unmute. If you're a participant in this call and you'd like to ask a question verbally, that's fine. So Sarah, if you'd like to elaborate, we'd welcome that. Oh, I can't hear Sarah, but I do see MA equals Medicare Advantage, of course. You were asking what
Direct benefit.
yeah, some clarification on direct benefit. I think they might just mean if someone's living in a state where MA maybe not does not have a direct benefit, maybe not applicable, maybe. Those individuals go back to traditional, or does MA default to traditional?
Oh, so if in all cases, if a particular beneficiary is not in a plan that had opted in to the VBID model's hospice component, their beneficiary would be switching over to fee-for-service once they go into once they elect hospice. It's only in cases where oh, Sarah, if you're saying something. I hope that answered your question.
Give it a second or two more. If there's any other questions that come in on this topic, I'm looking to see if our next presenter is online. We'll give just a second for if there's any other questions. Well, wonderful. Thank you, Daniel. Thank you, Yixuan, for the presentation today on Medicare Advantage. And we really enjoyed your presentation and appreciate y'all joining our call. We're getting some thank yous through the chat box too. So it's not just our planning committee saying thank you, it's our membership as well. So thank y'all.
Well, thank you for inviting us to come and talk.
Our next presentation will be on predictive models and bias risk. And I am looking to see if our presenter's on. Her name is Dorothy Andrews. I wasn't seeing it a second ago, but I'm gonna give it one more look through. We'll begin as soon as Dorothy's online. So if everybody just wants to hang tight, we'll just hang tight. Unless Dorothy, you're on here, in which case just give a shout. Because I see some of the people come in as nicknames and things like that, shortened names.